Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar series. Today's topic is Aging with HIV, and we have Dr. Trupti Gilada with us as a facilitator. Dr. Trupti is the infectious disease specialist, and she is an infection disease physician at Unison Medicare and Research Center in Mumbai, which is one of the very few comprehensive infectious disease centers in the country. She is also in charge of the infectious diseases departments at the Sefi Bhatia and Messina hospitals in Mumbai. During the COVID pandemic, she was actively involved not only in the clinical treatment of COVID patients, but also with prevention education programs and policy making. We welcome you, ma'am, for today's NDLS session. I would request Dr. Tripti to kindly initiate the session.
Good afternoon, everyone, and thank you for being here on a post-lunch session. So let me just check if is that visible?
Yes, ma'am.
Thank you. So in the next 40 to 45 minutes, we'll talk about aging with HIV. And then we can have some discussion, and we can see how, with all this information that we have, how do we manage our patients in a better way. This is the outline of my talk. We'll see how the trends in the age of the population are changing. What are the considerations before treating HIV in aging? And then managing age-related non-HIV comorbidities. This is the list. And then at the end of it, we can have our question answers. So talking about the age of the patients living with HIV in our country, we will see that with every year, the population or the proportion of people above the age of 40 years is increasing. And that is because of two things. One is that with the availability of HIV on such a large scale, patients with HIV are living longer. Second thing is that the incidence of newer infections is down, which means the people who are getting infected are living longer with HIV. They will grow old with HIV. And the third important thing is that in general, our population pyramid of the country is such that over the next few years or next few decades, the age group between 35 to 50 is going to keep increasing. And therefore, we are going to see more and more patients with HIV and above the age of 50 years. And when we talk about this population, what's important to understand is, can I just move this window somewhere? Is it possible for me to move this? Okay, the Zoom window. I was able to do it. Thank you. So when we compare the overall and the comorbidity-free life expectancy between adults with and without HIV, and this is data not from India but from abroad, you will see that those without HIV definitely live longer than those with HIV. And this is true even when they are put on treatment. And so while we might think that ART is prolonging life, what we need to remember is it still doesn't give them the full longevity of life. And this is data from our own center about the age group of HIV. And you will see that those above the age of 50 is pretty much a majority of the chunk now. And there will still be people who are diagnosed late and those with new infection. And these are two groups that we should not forget about. And a lot of these individuals are diagnosed late because of low voluntary testing. Sometimes these individuals will land up at other places for other health issues, but the suspicion is low and therefore they're not tested. And sometimes they really present late for diagnosis and care. We are also seeing newer infections in this age, and we are able to confidently say new infections in certain individuals because they have a previous HIV report, which was negative a few years back, which was done either for a surgery or a hospital admission. And this is one group that we definitely need to attribute and not forget about. And this is often because these are individuals who are newly single because they've lost their spouse. There's a lack of awareness in this population. They do not really perceive the risk. and there is low condom use, because if there is no risk of pregnancy, then they wouldn't think of using a condom at all. So what are the considerations before we treat these patients with HIV? The first thing is that to remember that the mortality in these individuals is no longer AIDS associated. The mortality in these individuals is now moving on and is a lot of other non-AIDS related illnesses. And this is only in 2009. We are almost 2 decades after that, and it's much lesser now. The other thing is that in our own country, if you see the causes of death, even in the non-HIV individuals, the causes of death is mainly non-communicable diseases, be it heart failure, COPD, strokes, diabetes, chronic kidney disease. So in general, the other infectious diseases which would otherwise cause mortality in those HIV is decreasing. And non-HIV comorbidities is definitely increasing. So if you see right from age 45 to 65, how individuals with 1 or 2 or 3 comorbidities constantly keeps increasing. And more comorbidities means more medications. So while majority of the individuals who are less than 50 years of age might only be on ART and nothing else, as they age, the number of pills because of other comorbidities constantly keeps increasing. So for the patient, while for us managing these individuals with aging and HIV is a lot of those diseases, for the patient, it is increasing expenses with decreasing income. The pill burden increases. There is increasing hospital or doctor visits because they will visit once for the ART. They might have to visit again for a diabetes or a blood pressure or any other illness. And with restricted mobility and increasing dependence, treating these individuals, not just for HIV, but for all the other comorbidities is a challenge which we need to address. Like I was saying, ART definitely decreases event risk, but it does not normalize it. So if you look at the dark blue bars, the dark blue bars are the mortality or the risk of infections and strokes in the first year of diagnosis. And after the first year of starting treatment, if you look at it, the risk definitely decreases. But if you see this red dotted line is the standard risk in the general population. So even with ART, you will see that the risk is never normalized. There is always a risk that will still remain. And why is that? If you see that, for all diseases, we do this triangle. So in patients with aging and HIV, there definitely are certain risks like gender, age, menopause that we really cannot do much about. And then there are traditional risk factors like smoking, dyslipidemia, hypertension, diabetes, some of which that we can address with medication, and some of which we will need to talk to patients about and counsel them about modifying. The other thing is poor engagement in care. So a lot of times relatives will come for a refill, and therefore the diagnosis of these illnesses will either be missed or delayed. And to add to this is poverty, because these are individuals who are often retired and financially dependent on someone else. There are risk factors of the virus itself. And we know that despite ART, there is an ongoing inflammation and immune activation, which adds to the risk of these non-communicable diseases. And co-infections and late diagnosis only worsens it. And the third important part is the treatment itself. ART itself has certain toxicities, has certain drug-drug interactions that we need to keep in mind. So coming to each of these non-HIV comorbidities one by one, coming to our biggest one, which is diabetes mellitus. So the relative risk of diabetes in HIV infected is 1.2 to 2 times. And with the advent of dolutegravir-based regimen, we are waiting for bigger studies from our country, but we know that this risk might be even more. The prevalence of impaired glucose tolerance is around 18 to 35%, while the risk of diabetes mellitus itself is around 10%. The other thing that we need to remember is that several studies have shown that when we look at HbA1c per se, it often underestimates the glycemia in HIV infected persons. So while a 6.5 cutoff in a non-HIV individual might be diabetes, for an HIV infected, that cutoff might be even lower. And that's just something to keep in mind, that HbA1c definitely underestimates glycemia in HIV individuals. So with this understanding, how do we diagnose these individuals with diabetes? The fasting glucose, more than 126, a postprandial of more than 200. If we do see an impaired glucose tolerance, and by impaired glucose tolerance is anything between 100 and 125, then we consider a post meal as well, if a fasting was higher, and the HbA1c of 6.4 or more. When do we do this? It's fasting glucose every 6 to 12 months. So we do it once at ART initiation. The second one we will do at around 3 months after starting ART, or if we are modifying ART to another regimen, and thereafter every 6 months. The drugs that we must remember, which are common culprits, is lopinavir, which isn't used anymore. Isn't used that much anymore, and some NRTIs. And also remember that dolutegravir has a risk of increased weight gain. And these individuals who have very rapid increases in their weight are definitely at a risk of metabolic syndrome, and diabetes is one of them. Managing them, like all other of these illnesses, is we really need to individualize therapy. There is no one cap fit all. So it will have to be modified based on what drugs they are, what are the drug-drug interactions. And the goal to prevent complications in HbA1c, in younger individuals, your goal of HbA1c would be 6.5 or lesser. In older individuals, in elderly, the risk of hypoglycemia and the down effects of hypoglycemia are much more. And therefore, we are a little more liberal with the HbA1c, and 7 or even 8 is acceptable in the elderly individuals. When we see the drug-drug interactions of all our oral agents for diabetes, you will see that with dolutegravir, all of them are safe, except for metformin. And we need to remember this, that the levels of metformin are increased when they are co-medicated with dolutegravir. So in non-dolutegravir receiving individuals, the maximum dose of metformin is 2 grams per day. And this is the dose that will need to be modified when the patient is receiving a dolutegravir-based regimen. When you look at all the other drugs, there are no drug-drug interactions. So these are the most commonly used drugs. The protease inhibitors, definitely we need to look up the drug-drug interactions for protease inhibitors. And with darunavir and atazanavir, we need to keep that in mind, that we will have to look up the drug-drug interactions. One, it's practically not possible for anyone to actually remember each of these drug-drug interactions. So one of the easy tools to look up drug-drug interactions in these individuals is the HIV drug-drug interaction database. And on the last slide, I will be sharing a link to all these very easy to access tools that can be accessed just over the cell phone. Coming to cardiovascular diseases, with increased longevity, there is an increased risk of cardiovascular diseases, and just being HIV infected itself increases the risk by 1.5 to 2-fold. And the risk of sudden cardiac death is as much as 4.5-fold. Then before we get into all the cardiovascular diseases, one thing that, just a quick revision about metabolic syndrome. Metabolic syndrome is the entire spectrum of illnesses, and not just illnesses, abnormalities, which are categorized by any of these 5. And 3 of these 5 would mean that someone has metabolic syndrome. And if you look at each of these are very easily available to us. Visceral obesity means just checking the waist circumference. We just spoke about insulin resistance. Insulin resistance is any fasting glucose above 100. Just to not, so that you do not get confused, the definition of diabetes is different. So impaired glucose tolerance or insulin resistance is any fasting above 100. So if you see a fasting above 100, there should be a red flag in your mind that this person could progress to diabetes in the future if not managed properly now. Blood pressure, any systolic above 140 and or diastolic above 90, and two values from the lipid profile. So a low HDL level and a high triglyceride level. So anything above 150, or even if it's less than 150 and someone is being treated for it. So any of these three means the person has metabolic syndrome, and having metabolic syndrome itself adds to the cardiovascular risk. So the first step in managing cardiovascular risk is identifying who are at risk. And like I said, 5 of these are very easily available to us on blood pressure, diabetes, the lipid value, and the waist circumference. The others will be available to us on history taking. So what is their physical activity like? Do they consume tobacco or alcohol? What is their diet like? Is it a lot of street food, junk food? And was there or is there any history of cardiovascular diseases? So once we know these risk factors are there, the assessment for this cardiovascular risk needs to be done periodically. And while we might do it first time at ART initiation, it needs to be repeated at 3 months after the first time it's initiated, and thereafter every 6 months. So just doing it once and forgetting about it later on really does not help, because as our patients grow old, many of these risk factors that did not exist earlier might start getting added. Like people who are working earlier and get retired might now have a sedentary lifestyle. A lot of medications might get added on. Sometimes in elderly, the alcohol consumption might increase because these are individuals who are at home, lonely, or just spending time with other elderly friends. So read asking this history at every visit and assessing the parameters that we spoke about. And once we understand all this cardiovascular risk, is then managing these individuals. And the most important thing in management that is most important but often under-addressed is lifestyle modifications. And that's one strategy that works those with cardiovascular risk and those with low risk but who are aging. And then to help the lifestyle modifications is the pharmacologic therapy, which is choosing a lipid-safe ART. Sometimes these individuals might require lipid-lowering agents, management of the metabolic syndrome and diabetes with metformin, and keeping in mind the interaction of metformin with dolutegravir. And those with a really high cardiovascular risk, definitely avoiding the avacavir-based regimen. So coming to lifestyle modification, though we all know this, there are a few things that we must talk to our patients about. The first thing is exercise. Let's go to A, avoid tobacco. So those who are smoking or chewing tobacco must be reminded and encouraged every time to quit that, to quit tobacco or smoking. B is being more active. And while we might say that you must exercise, it always helps when you tell the patient that you need to spend at least 30 days every day doing aerobic exercises, which could be either walking briskly or running or cycling or swimming. Oftentimes, if you tell them that make sure that you choose a temple and you walk to the temple or a mosque and you spend 30 minutes at least 5 days a week. And then addressing their diet and stressing about lowering saturated fat in diet and increasing fruits and fiber intake. So just to give you a visual impression of how much lifestyle modification helps, this is with no modification and doing nothing. This is with metformin. And once you add lifestyle itself, the improvement is really much more. And, there is definitely a cumulative improvement once you do a lifestyle and drug therapy. So coming to choosing the right ART for these individuals, this is a very easy graph to just help you understand which are the ones that are with low risk to the lipid profile in the individual. And if you look, most of the drugs that are used as first line, so which is tenofovir with dolutegravir, are actually pretty lipid safe. The ones that are not, or are lesser safe, are protease inhibitors, and to a lesser extent efavirenz and abacavir. So our treatment, when our management goals, when we are managing these individuals with hyperlipidemia, is to lower the non-HDL and LDL cholesterol to less than 170 respectively. So, really don't go into these little details, but just remember that we really need to get their LDL to less than 70 and then non-HDL cholesterol to less than 100. And that should be the target. In fact, talking to the patients that, this is your cholesterol and this is the value that we want to target, it really helps them, because it also gives them a visual impression of where they are in terms of their values and cardiac health. Talking about drug-drug interactions with our ART, most of the drugs that are commonly used, whether it's dolutegravir and NRTIs, they are all pretty safe with all anti-lipid therapy agents. With darunavir or atazanavir based regimens, so darunavir, atazanavir increases the levels of the statins, and therefore the maximum dose of statins with PIs is lower. So while the maximum dose of statins with dolutegravir or other atorvastatin is around 80, when we are actually using it with PI, we do not want to use a dose of more than 40 milligrams for atorvastatin, equivalent for other drugs. So the lipid lowering agents, the statins, will decrease 44% reduction in risk when lipids are high. In those with triglycerides of more than 400, phenofibrates should definitely be considered. And the usual dose of statins required in these individuals is around 40 to 80 for atorvastatin and 10 to 20 milligrams for rosuvastatin. The reason why I'm going to discuss a few doses is that oftentimes the patients will go to two different clinics, one for ART and one for the management of their blood pressure, diabetes, and lipids. So the other doctors might not keep that in mind about the ART. So it's always good that the ART officer just has a watch over what is the dose of statins or what is the dose of metformin and dolutegravir that is going, and you can address those concerns if ever required. A quick thing about a second risk calculator, which is easily available over the cell phone, and I will be sharing a link of this as well. So what this does is, once you enter in all this detail, male, female, and what the blood pressure is, what the cholesterol is, and the risk factors like diabetes, smoker, whether the person was statin or no, it gives you a lifetime risk. And along with giving you a lifetime risk, it pretty much also gives you some tips or advice summary that the patient can follow. It will talk about intensifying statins and starting or continuing aspirin. So for individuals who have more than one or two risk factors, this calculator really comes in very handy. Coming to bone health and osteoporosis. So the bone mineral density is either osteopenia, osteoporosis, fractures, and avascular necrosis. The risk factors, the ones specifically to this risk group would be, so the ones that are here are the ones that are most easily modifiable. So smoking, alcohol, vitamin D deficiency, and hypothyroidism. We need to keep in mind, again, ART and toxicity, and keep in mind if these individuals are on glucocorticoids for any reason. And in the other viral markers, along with CD4 and viral load, the other thing is to make sure what the hepatitis C status is. So in those people living with HIV, there's a 6.4-fold increased risk of low bone marrow density and 3.7-fold increased risk of osteoporosis. And that is both in men and women. So not necessarily only women. And yes, the risk definitely increases much more in women after this age group in menopause. Even in India, in ART naive individuals, the risk of osteopenia and osteoporosis is around 70 and 30% respectively. And once ART is started, this risk definitely goes up. And we know that that is because of our tenofovir-based regimens. So there is, once again, there is a very easy score, which is called the FRAC score. But even if we do not access that score, what we need to remember is individuals above 40 who menopausal, who had a risk of fracture, or for any reason in whom a DEXA scan was done or an X-ray was done, and sometimes a vertebral X-ray is done, and the radiologist will comment on osteoporosis. In those individuals, we know that there is definitely a risk of fracture in the future. And in these individuals, we need to ensure adequate vitamin D and calcium, lifestyle modification, and then work them up for any other treatable causes of secondary osteoporosis. So just to give you a screenshot of what the FRAC score looks like, where you just enter the country. For secondary osteoporosis, you enter yes, because HIV itself is a risk for osteoporosis, and then you fill in all the detail, and then it gives us the osteoporotic risk and the hip fracture risk in the next 10 years. So once you've addressed the lifestyle modifications, then most of our patients are vitamin D deficient, so we really often don't even test them for vitamin D. We just prescribe vitamin D to these individuals on an annually, along with calcium. In terms of ART, we would often want to switch them over to safer ART. So if there is someone on a TDF-based regimen and they are switched to a abacavir-based regimen or a TAF-based regimen, and if they're on a PI-based regimen, then to a DTG-based regimen. And I will tell you in short about bisphosphonates. So those with osteoporosis or with a history of fracture, then there is a definite benefit of giving bisphosphonates, which is either alendronate or zoledronic acid. So this is just to show you that how TAF regimens, tenofovir alafenamide, which will become available in the future on a larger scale in the program also. So TAF-based regimens definitely have lesser impact on the bone marrow density. And this is lumbar spine, and there is a significantly less impact with TAF compared to TDF. And this is the benefit of zoledronic acid versus just switching from TAF. So zoledronic acid is given as a 4 milligram once a year injection, or alendronates or bisphosphonates are given to these individuals every week. And you will see that there definitely is a change in the bone marrow density pretty much in the first year itself. So it's important to differentiate osteomalacia and osteoporosis in these individuals. So osteomalacia is because of vitamin D deficiency, and the treatment in this is treating them with vitamin D. In osteoporosis, yes, you will give them vitamin D and calcium to just improve bone health, but doing that much is not enough. For those with osteoporosis, they really need bisphosphonates, and depending on what is given and when we started, there is varying response. So the earlier this treatment is given, the better it is for their bone health. One little thing about the drug-drug interaction of dolutegravir with calcium and iron. So dolutegravir can be co-administered with calcium and iron supplements if it is taken with a meal. But in case it is taken in the fasting condition, then dolutegravir should either be given 2 hours prior or 6 hours later. So if the patient is going to take it with a meal, they can definitely do it all together. But in the fasting state, we must space those drugs apart when the patient is on a dolutegravir-based regimen. Coming to renal disease, so there are several causes or individual predictors of new onset kidney disease in these individuals. And in addition to the traditional risk factors like the BMI, smoking, hypertension, age, and diabetes, there definitely is some risk with HIV itself. The risk of HIVAN or HIV-associated nephropathy is much lower now. Now there is test and treat, and everyone receives ART very early. But we must remember that drug-induced new onset kidney disease is a risk. The two important drugs is analgesics, because a lot of time these individuals have pains and aches and will consume ibuprofen, combiflam several times in a week, and that adds to the risk of a kidney disease. And in that background, even tenofovir can cause a new onset kidney disease. So with low risk of a kidney disease, where you can screen that using your serum creat and a urine dipstick, which will tell you how the proteinuria, if there is any proteinuria. So those with a low risk, and if you see, being less than 50 is low risk, and being more than 60 anyway adds to some risk of a kidney disease. So the standard ART can be given. But if there is high risk, which is a estimated GFR less than 70, or a protein creatinine ratio of more than 500 in the urine, and age more than 60, or any of these conditions which these individuals might have, which is diabetes or uncontrolled hypertension or cardiovascular disease, then in these individuals, nephrotoxic drugs should be avoided, TDF and atazanavir being the most common ones. And for other NRTIs, dose adjustment is required except for abacavir. So in those with a renal disease, the drug of choice is abacavir plus dolutegravir based regimen. So abacavir, lamivudine and dolutegravir can be given. It was earlier believed that lamivudine would require a dose adjustment, but a lot of recent data has shown that it is absolutely okay to not adjust the dose of lamivudine, because the risk of splitting up that tablet into 3 different tablets, so an abacavir, a dolutegravir, and then a decreased dose of lamivudine, has a lot of compliance issues, and that risk is much more than the benefit of giving a full dose lamivudine in a single tablet regimen. So that's about the drugs in renal disease. Coming to non-AIDS malignancies, these are individuals who are aging, and definitely the risk of cancers also keeps increasing. 3 important cancers that we must keep in mind is 2 of them in women, which is cervical and breast cancer, and oral cancer in both men and women who consume tobacco. So all women at ART initiation should undergo cervical cancer screening, and this is done with visual inspection with acetic acid. So what is done is a colposcope is inserted, acetic acid is applied, and the dysmorphic areas that pick up acetic acid are the disease areas, and biopsies are collected from these particular areas. And this is repeated every 3 years if the first test was negative, and for any reason, if the patient was treated for like we call it cervicitis, then these individuals are screened every year. So that's about cervical cancer screening. About breast cancer screening, what is available through the national program is only clinical breast examination. For those in the private sector, mammography is also advised. But talking about the program, the clinical breast examination is done for all women living with HIV above the age of 30 years. It should be done at ART initiation and every year. Oftentimes guidelines will say every 3 years. But practically, if you think about it, no one remembers that, oh, now it's 3 years since we first did a clinical breast examination and we should now do it. So these individuals should just have a clinical breast examination every year. And it really does not take too much time. It probably adds only 5 minutes to the entire examination. It's important to learn this technique correctly. It's an easy technique, but it's important to learn this technique correctly so that the patients get the full benefit of the clinical breast examination. So clinical breast examination is done both in sitting, standing, so either sitting or standing, and lying down position. So there is first to visually inspect if there is any asymmetry in the breast, and then on palpation there are different methods in which it can be palpated. So there is a concentric method where you go from in to out concentrically, covering all the areas of the breast, or you go vertically so that you cover all areas of the breast. or you start from the 12 o'clock position from outside to inside, like a radial spoke or a wedge technique. And then you come back to the 12 o'clock position. We need to make sure that while we cover all these quadrants, the upper inner, lower inner, and the lower outer easily, what is often missed is the outermost quadrant. And that is also one of the most common sites of the breast malignancy. So when we do this breast self-examination, we must make sure that we go right up to the axilla so that we do not miss the breast tissue in the Taylor's fence. So, there are beautiful videos of breast self-examination available, which will hardly take 4 or 5 minutes. So I would definitely recommend that go and look at one of these videos and, if possible, at least make sure that you're examining these women at least once a year. For women who are motivated and understand enough, we can even talk to them about breast self-examination, which is done every month, where women examine their own breasts every month and will come back to the healthcare worker if they find anything new or suspicious. About screening for oral cancer, all individuals above the age of 30 years should be screened for oral cancers, especially those who chew tobacco, and at least annually for the others. If there is any suspicious lesion, then they should be biopsied. And if the biopsy is negative, use that opportunity to tell the patient and remind the patient the benefits of quitting smoking and tobacco. Coming to two other important subjects, these are ones that we might still address, but two important subjects that are extremely important and often ignored are mental health and frailty. So the PL-HIV are twice as likely to have depression, because there's stigma, there's rejection by family sometimes or friends, there is financial insecurity, there is dependence, and there is the fear of falling ill, landing up in the hospital, someone finding out what if they are infected, and the fear of death, like everyone at that age would have. And over 50 to 75% of the study groups of older adults with HIV did show depression. So it's important that we address this, because not only does it add to the non-adherence to ART, it also adds non-adherence to all medications and also increases risk of self-harm. Screening for depression is extremely easy. We do it before initiation of ART and thereafter every 6 months. So there are two easy questions that are asked. You ask that during the past 2 weeks, have you often been bothered, or have you felt low or depressed or hopeless? And the second question is, have you been bothered by little interest or pleasure in doing things? And if the answer to any of these two questions is a yes, then in the ART booklet or the guideline booklet, there are 2 detailed questionnaires that can help you both gauge the level of depression and also score where the patient lies on the depression spectrum. But knowing this is often enough that there are some signs of depression, and just having a yes to these 2 questions should trigger all that we need to do thereafter, even while the scoring and those things are being done. And what are these things? The first important thing is, if the patient shows any sign of depression and is still on an efavirenz-based regimen, they should instantly be shifted to a non-efavirenz-based regimen, which would now mean a dolutegravir-based regimen. Just counseling and listening to the patient will often tell us what the problem is and might help them to cope with this, helping them with stress management, asking them to be busy. A lot of time, these are individuals who are retired and therefore have a lot of time at home, and just not doing anything makes them feel worthless. So asking them to keep themselves busy with something they like, or relatives, with grandkids, or picking up a hobby often helps. Joining social networks comes in like a big support group for these individuals, because just sharing their stories with each other, and they often have common stories and they often have common solutions, really helps them, because we might see them only once every 6 months, but they really need a constant social network outside of this clinic. And of course, sometimes these individuals might require and benefit from medications. Coming to frailty, frailty is called the sixth vital sign in geriatric population, and 3 out of these 5 means that your patient is getting frail. And a lot of these things will be given to you on history. A lot of these things you will be able to just see. Like you might see a weight loss, and if you ask the patient, did you actually do something to lose this weight? And if there was an unintentional weight loss, or if the patient constantly complains of fatigue, there is just low physical activity levels, things that they had done so easily a year or 2 years ago, and they're just unable to do now. Weakness that can be measured by just asking them to grip your hand. And you might just see them coming very slowly and a slow walking speed. So any of these or 3 out of these should give you an idea that your patient is moving towards frailty. And you will see that the prevalence of frailty in those with HIV is much more, and this is for all 5 of these signs, is much more than those who are HIV uninfected. And it's significantly more in terms of all the parameters. So again, it's got a multi-pronged approach, and the 2 or 3 most important things is encouraging them to do regular exercises, and along with walking or other aerobic exercises that they're doing, we must stress upon exercises that help them balance and flexibility training. In this sense, yoga really comes in very handy, because it helps them both with balance and flexibility. We spoke about social health, social networks and self-help groups, and talking about nutritional interventions, improving the protein intake in their diet. Oftentimes, we might need to objectively tell them that you need to start eating eggs or fruits or milk products, nuts. So not just telling them improve your diet, really telling them how they can improve their diet and how they can improve both protein and calcium in their diet will often help them. Beyond drugs, we need to make sure that the prescriptions that we give them are easy. A lot of times there are several drugs on their prescription. They will take a few, they will miss a few, they do not know what they are missing, and they will not be able to give us the right history even after they come back. So making prescriptions that are easy to understand and that are easy to follow, stressing about nutrition, involving family. A lot of times these individuals come in alone, but if their family or someone in the family is aware about that status, we should encourage that they come in with someone at least for a few visits, so that from them you get to know how they're doing at home. And a lot of these things about nutrition and exercise is something that you can convey to their family members, so that back home they can ensure that all these things are taken care of. Asking open-ended questions, addressing their mental health, and avoiding multiple health visits. So if there is a way that a lot of these consults can be done for them at a single place or on a single day, instead of calling them once for the ART and then another day for hypertension and blood pressure, if there is a way that we can consolidate their entire visit within a few hours, it really goes a very long way in offering comprehensive health to these individuals. So to conclude, we really need to help these individuals age with grace. So look beyond what are we seeing. We have to widen our management focus and look beyond ART and look beyond just their CD4s and viral load, and look at the other reports as well. Strengthen our screening strategies. So when available, ask for lipid reports, ask for blood sugar reports. Make a note of what their weight is and what their blood pressures are. A one-stop shop as far as possible, so that they all come in on one day. While lifestyle changes remains important, please remember that we must try and use statins and bisphosphonates whenever it's possible and needed. In these individuals, this is one group of individuals where we really need to optimize our ART and move beyond the standard TLD, or whatever standard that we are giving. These are individuals who might really need, they will not come telling us that change our ART. We will have to actively look for other risk factors and optimize their ART. Vaccination not available through the national program yet, but it is something that needs to be kept in mind for those with aging. And the most important thing is just listen to them, because, just giving them that extra few minutes to just listening to them really makes a lot of difference. These are a few online tools. You can take a screenshot if you need of, like I was telling you, the drug-drug interactions, a very easy tool where you just put in your ART regimen and put in the other drugs as well, be it nephrology drugs, blood pressure, diabetes, even hepatitis C medications. You put that in and it will tell you what the drug-drug interactions are. For eGFR measurement, the FRAC score is for the bone health, the cardiovascular is scoring, and a lovely database, drug resistance database, which comes in helpful for those with failing regimens. So that was my last slide, and I would really like to thank my patients and teachers and the institutions that have made me and helped me what I am today. So thank you once again. You know, it's so fortunate that we're even talking about aging, because sometimes people do not even have the privilege to age. So it's great that we're talking about aging, and we hope that we are able to help our patients really age well now that that privilege is available to them. That's my email ID, and if there are any questions, even in future, you can write to me. And for now, we can have questions and answers. Thank you so much for patient listening.
Thank you so much, ma'am, for this informative session. Participants, if you have any queries, you can just unmute yourself and ask. Ma'am, there was one question in the chat.
Yes, I'm looking at the question. So there is a question about the lamivudine in the national guidelines. I agree that the national guidelines have not changed yet. And therefore, based on national guidelines, you will still have to follow the guidelines and change the regimen. All that I wanted to do was make you aware that there have been studies that have shown that it might not be required to change lamivudine. So if there is a scenario where you really cannot modify the regimen, then this might really come in handy. But for now, I think you will definitely have to follow the guidelines. I'm just going to have a look at all the questions in the chat to see if there's something in there. So even without weight gain with DTG, some have hyperglycemia. Yes, I agree. We are seeing more and more impaired glucose tolerance and diabetes with the advent of the DTG era. I think that's all in the chat box. If there's anything else, you can please feel free to unmute and ask your question. Dr. Vishwanath Rao, did you have a question? So if there aren't any questions,
sorry Trupti, can I ask a question, please?
Yes, please.
Thank you for a comprehensive talk. I just wanted to emphasize on the fact that even though you mentioned about looking at for women cervical examination by the by application of acetic acid, remember in that slide, visually excluding or screening for cervical cancer, I think is not really a good method, or it has a lot of false positives with the technique. And therefore asking an older woman about unexplained bleeding, unexplained discharge, and something that we don't tend to ask. We're not worried about sexual infections in these women. So therefore asking about unexplained patterns of a change in their discharge, a change, they noticing some blood during wiping or cleaning, or, becomes a better indicator in the setting that we are talking about. Because I can't imagine people doing visual, using acetic acid and then trying to exclude cervical cancer. It's a very poor tool, and which is not practiced, in many countries anymore. So therefore, just clinically talking to the patient, as you emphasized, we should be talking to them more. So asking about female-related issues, becomes important. And I was glad you mentioned self-examination, because that's, again, empowering people to look after their own health. And I think these are better sort of, but as healthcare professionals, we need to be asking as well. So I just wanted to add that.
Yeah, thank you so much. That was very important. And to add to that, also for, since we do not have any screening for GI or colon cancer, also asking if there is any change in bowel habits and any blood in stools also will help us choose those individuals who will require further workup for a colonic malignancy.
Hello. Ma'am, I'm Dr. Kaur from Barampur Medical College, Odisha. I would like to know, actually, we previously thought that only TLD is nephrotoxic. But as you said, we'll have to be a little more careful when we prescribe atazanavir, ritonavir, and lopinavir, ritonavir. Is it? Should we be careful?
Yes, so those who already have an nephrotoxicity, we are definitely more careful about using atazanavir, ritonavir. They do not really cause a rise in like the way it does, but in those existing diseases, we would want to, now that the it is available to us, we would prefer using atazanavir to a PI-based regimen or atazanavir regimen in that scenario. There was another question on the same lines. If someone can explain what is of creatinine clearance, AL can be given with close monitoring. Can you, if whoever, Mr. Dr. Rajiv Dev, if you can just explain that. I'm not sure what AL is. Or you mean abacavir lamivudine is what you're saying? If that's right. There was another question about a gap between calcium and dolutegravir, and yes, we definitely leave a gap between calcium and dolutegravir or space them because the absorption is not affected only if they are taken with food. And oftentimes we're not sure whether the patient will take the medicine in a fasting state or with food. Therefore, a gap between calcium and dolutegravir is advised at all times. But just to give that little nitty-gritty, if it's actually taken with food, it wouldn't make a difference.
Ma'am, what creatinine clearance level can we start tenofovir?
We will definitely avoid tenofovir in anyone with a creatinine clearance of 70 and less.
Okay.
We have options now, so we would definitely avoid tenofovir at that 70 and less.
Thank you. Thank you.
So yes, Dr. Rajiv, they were saying that in case single lamivudine isn't available, then we can use the FDC of abacavir lamivudine. That's right, as per the guideline as well. Thank you. Yeah.
Ma'am, out of the way, can I ask you one thing actually that troubles us? Where if a patient of hepatitis B is taking ALD, suppose, then can we add can we add TL to that? There's no single tenofovir, but
yeah,
we can
so
add TL.
No, so if the tenofovir was consciously avoided because of an adverse effect, then in these individuals, hepatitis B, we add an entecavir. So if the tenofovir really needs to be avoided, then entecavir is added to the ART regimen if it doesn't cover for hepatitis B. So someone on an ABC-based regimen, we would add an entecavir. Is that helpful?
Not for adverse effect. If we are avoiding tenofovir for failure, as in case of failure of tenofovir, we are going to AL. then can we, in a case of hepatitis B, can we add extra TL to that?
No, so the thing is that if someone is failing a tenofovir, ABC would not be the drug of choice for them anyway, because they both work
Yes.
on the same mutation.
No. Maybe for any other drug, that is, if not AL, we can add actually that actually suscept. They usually, whenever there is failure with TL.
So for example, yeah. So for example, say for hypothetical example that your patient is on dolutegravir plus the darunavir based regimen and you need to add something for hepatitis B, yes, you can definitely add tenofovir.
No, can we add both? There is no single tenofovir available, but we can add TL that if it is possible, if it is present in our.
Yes, that's right.
Okay. Thank you, ma'am.
Hello. Hello.
Yes, I can hear you.
Ma'am, thanks for the session. I have a query. You mentioned that the maximum dosage of metformin in patients with the dolutegravir is 2 grams per day. Is it 2 grams or 1 gram?
In those without dolutegravir, the maximum dose of metformin is 2 grams per day. But once the patient is switched to a dolutegravir based regimen, you might need to lower the dose of metformin because metformin levels would increase and therefore you would need to lower the dose of metformin and monitor.
Yes, thank you. Yes, thank you.
The maximum we provide, Trupti, is a gram metformin.
Yes, a gram. That's right. Yes.
We don't go beyond a gram.
Thank you, everyone, and thank you, organizers, for this session.
Thank you, madam.
Thank you, ma'am. Thank you so much. Thank you to all the participants.
Have a nice day, all of you.
Thanks,
Have a good
guys.
day.
Thank you again. We'll end the session now.